We are live now. With all your permission, I'm starting this session.
Okay.
A very good evening, everyone present here. I welcome all the participants on today's session. Let's welcome today's speaker with great honor, none other than Dr. I.B. Vijay Lakshmi ma'am. Ma'am has done MD, DM, DSc, FRCP from London, Professor Emeritus Formal HOD of Pediatric Cardiology at Sri Jayadevan Institute of Cardiovascular Science and Research, India. And before starting this session, let me tell you overview of the topic. Recent advances in heart failure management have introduced more effective medication like valsartan, enabling better outcomes. Telehealth and remote monitoring play a crucial role in continuous patient care. And innovating surgical options like LAVCD provides new avenues for treatment, including destination therapy. To know more about this topic, I would like to invite ma'am and hand over this session to ma'am. Ma'am, over to you, ma'am. Kindly proceed from here. As ma'am is facing some technical problem, she will be joining in just a second. I request all the participants who have joined this session, if you have any question related to this topic, you can note it down and put it in the comment box. And once ma'am talk is over, we will take these questions one by one. I once again welcome all the participants on today's session. As for today's session, the topic is advances in the heart failure management. And for this topic, we have speaker Dr. I.B. Vijay Lakshmi ma'am. Before starting the session, let me share some of the overview of the topic. Recent advances in heart failure management have introduced more effective medications like scobitril, valsartan, enabling better outcomes. Telehealth and remote monitoring play a crucial role in continuous patient care, and involving surgical options like LVADS provides a new avenues for treatment, including destination therapy. And to know more about the recent approaches for heart failure management, ma'am will be joining us in any moment as she is facing some technical issue. Like ma'am has joined us and she will be starting her presentation very soon. I request all the participants, if you have any question related to this topic, you can just note it down and keep it in the comment box. Once ma'am is finally here. Ma'am, I would like to hand over this session. Ma'am, most welcome. I have already introduced you. You don't need any introduction. Yes, already famous on the digital platform in the sharing of the knowledge, ma'am. Over to you, ma'am.
Thank you so much. Good evening, everybody. It's my pleasure.
Ma'am, you
Though
can
I'm
make
not,
the presentation, ma'am.
yeah,
Sorry,
yeah.
on the full.
Though I'm not well, it's my pleasure to be with you all. I hope you can hear me, though my voice is broken. So, today I'm going to speak about the recent advances in the management of heart failure. The heart failure is defined as a chronic progressive condition in which myocardium is unable to pump enough blood to meet the demand of oxygen and nutrition. Heart failure has very high morbidity and mortality with almost 5 years mortality rate of about 50%. The most common causes of coronary artery diseases, hypertension, are in adult, whereas in children, it is the complex congenital heart diseases with the right and the left-sided heart failure. Approximately 30 to 40% of the patients with the heart failure are hospitalized regularly. 5 year mortality is a whopping 60% in men and 45% in women, as per the assessment in 1971. In 1991, the data from the Framingham Heart Study showed that 5 year mortality rate remaining unchanged with a median survival of just 3.2 years for men and 5.4 years for women, despite medical treatment. The most common cause of death is progressive heart failure, but sudden death may occur on account of up to 45% due to the arrhythmia. Higher mortality rates are seen in the diabetic patients. So, according to the 2022 American Heart Association guidelines, recommendations for the clinical assessment of the history are very important. And here, in patients with a heart failure, vital signs and evidence of clinical congestion should be assessed at each and every time the patient comes to us. And apart from that, the patient with the cardiomyopathy, a 3 generation family history should be taken. And in patient presenting with heart failure, a thorough history and physical examination should be directed towards the making the diagnostic strategy. And in patient presenting with heart failure, a thorough history physical examination should be obtained and performed to identify cardiac and non-cardiac disorders, lifestyle and behavioral factors, as well as the social determinants for accelerating. And for the pediatric heart failure, early recognition of heart failure in child is very important because proper institution of the appropriate intervention is often crucial for the survival. If we do the intervention in time, we can literally save the dying patient and give a whole life to the child. And this is particularly true in the infants and the newborn babies with the rare conditions, which I'm going to show you as I proceed. So, persistent tachycardia of more than 160 per minute, tachypnea, hepatomegaly of more than 3 centimeters, cardiac enlargement on X ray as well as the CT ratio, weight gaining more than 100 grams. Because of the water retention, salt and water retention, the baby will be gaining more weight, and that also has to be considered in the newborn babies. And how to recognize the heart failure in infants? Feeding difficulties. If there is a suck rest suck cycle, that means the baby has got the left ventricular failure. If there is a tachypnea more than 45 minutes, respiratory grunting, and the lower chest retraction, that indicates that the patient has got the heart failure. And persistent tachycardia, hepatomegaly, excessive sweating. And this, especially on feeding, is very important. Now, signs and symptoms of heart failure more closely resemble that of adult in a grown-up child like this. So the JVP is raised, edema is there, crepitations are there. Now coming to the management, we have the three-pronged action. One, generalized stabilization, invariably diuretic, and inotropes, vasodilators, you all know about it. The next one is the comorbid conditions like anemia and infection to be corrected, if there is any arrhythmia to be corrected. And I will go specifically to the identification of underlying heart disease and planning the definitive intervention. And this is what the new inventions are. So here increased preload like the left-right shunt, ventricular septal defect, patent ductus arteriosus, aorticoventricular tunnels, or the AV fistulas. They all will increase the preload, and that's why heart failure. Severe anemia, increased afterload, like in hypertension, renovascular hypertension, aorta arteritis, that is the non-specific aorta arteritis, coarctation of aorta, or congenital aortic stenosis with either bicuspid or unicuspid aortic stenosis. And apart from that, arrhythmias, complete heart block, incessant tachyarrhythmias, all can lead to the heart failure. Now, coming to the decreased contractility, invariably we see in the viral myocarditis, pericardial effusion with tamponade, cardiomyopathy, dilated or hypertrophic, Kawasaki syndrome, metabolic, electrolyte or hypothyroid, and myocardial contusion, toxins and cardiotoxicity. These are all the possibilities that has to be kept in mind. And in the infant, if there is a large ventricular septal defect within 6 months, invariably the child will present with repeated respiratory infection, grunting, and the lower chest retraction. You can see that there is a subaortic large VST, and this is a mid-muscular large VST. So this can be made out on the echo. And this is the Swiss cheese VST where the multiple VSTs are there. So invariably, though each VST is small, the summation of all these VSTs will make it a patient to develop heart failure. So coming to the specific case presentation, this is a 15-year-old boy with the recurrent lower respiratory infection, and pulse rate was 100, BP was 94/60, and Pextus carniaretum was there, bilateral Harrison sulcus present, indicating that the child had heart failure in the early childhood. So precordial pulsations, cardiomegaly were present, and echo showed multiple VSTs. So this patient had undergone surgical patch repair earlier in 2011. And despite that, that patient had come with a failure because after 6 months, once the pulmonary artery pressure came down, the small multiple residual VSTs, they opened up, and then the shunt became more. So in this patient, repeat CAT showed that 2.6:1 shunt was there, and the peer pressure was a whopping 95/68. And this is in spite of the one surgery. So during this, the surgeon refused to touch the patient because the redo surgery with the large peer pressure, and it would have been very difficult, and the morbidity, mortality is very high. So the patient was referred to me. And here you can see that the multiple VSTs are seen, and almost this is a Swiss cheese. So I put one device, two devices, and ultimately 3 devices were put. So this is another 9 months old baby with a large midmuscular VST, and the patient was not fit for putting the transcatheter device because the baby was too small for the huge device to put. So we did the hybrid surgery. The surgeon opened the heart and then made a small nick on the right ventricle, and through which I put my dilator, and then saw that this is the surgeon helping me, and that is me. And this is how we, with the help of the echo, a large VST was closed with the device, and this patient made a good recovery. After that, you can see that there is a huge VST, and this is the very, very large VST, and the patient made a complete recovery, and the small AST was kept as a vent so that, in case there is a suicidal RV, there is a right to left shunt. And after a few months, when the child grew up, we closed it with the another device for the AST. So this is the 8 months baby, 5 kilos baby, repeated respiratory infection. And you can see that we have put the device and then closed with the ADO2 6/8. And this is the 2 years old baby, just 8 kilos and repeated respiratory infection. Multiple VSTs were there. And then we did again the hybrid surgery, and the large VST also was closed with the device, and the small ones are also closed with the device. So this is how you can put a large device in spite of the baby being very small, less than 5 kilos. The transcatheter VST device closure is difficult, whereas we can do it in this is the 3 kilo weight, and the baby gained 3 kg weight. PA pressure dropped from 99 to 38%. So literally the patient going for Eisenmenger's can be prevented by doing this. Now we move on to the patent ductus arteriosus. Here you can see that this is the pulmonary artery, this is the descending aorta, and that is the large duct. And this is the device closing the duct. So this can be done very safely. But when the babies are very small, and that too 800,000 grams, now we have the Piccolo, that is the ADO2 additional size. And with that, we can go through even 3 or 4 French catheter. Now we move on to the pulmonary stenosis. So this is a newborn baby with the pinpoint pulmonary stenosis. Literally, you can see that this is the pulmonary valve. Hardly you can see the flow die into the pulmonary artery. Nothing is flowing into the pulmonary arteries because the stenosis is very severe. So we use the PTCA guide wire, floppy guide wire, over which PTCA 1.5 balloon, then 2.5 millimeter balloon, and then Ty-Shak 6 millimeter balloon. Graded, we went on dilating so that the patient doesn't develop the pulmonary edema. So in the newborn babies, the intervention is very risky, very demanding, but it is literally, life-saving. And this baby later on became a beauty queen, and she is a model now. And this is how a 3.5 kilo, this is another patient where we have opened up with the floppy guide wire PTCA balloon, and then with the 6/20 PTCA, Ty-Shak balloon. And this is how we can do the balloon dilatation. Now, on the other end of the picture, when the pulmonary valve is absent or it is not functioning, there is a severe pulmonary regurgitation in a cyanotic baby, and post-surgical pulmonary regurgitation, or in the absent pulmonary valve in the tetralogy of Fallot. In all these conditions, we have a transcatheter valve replacement. And here you can see that the severe pulmonary regurgitation, and that is closed with the transcatheter replacement of the pulmonary valve. And this is how we know whether the blocked valve can be opened to reduce the failure, or the leaking valve can be repaired with the transcatheter replacement. So this is the specific treatment. And this is the 8-year-old boy with giddiness, anasarca, and had a frontal glioma. And then you can see that the patient had a big problem. He had a pericardial effusion as well as the pleural effusion. And apart from that, the glioma which was there in the mediastinum was pressing on both the pulmonary arteries. And that's how we opened both of them. So LVOT obstruction. Now coming to the LVOT obstruction, any neonatal infant in a shock that does not respond to fluids or pressors has LVOT obstruction. And this is to be proved otherwise, until it is proved otherwise. So this is the dictum. So if you have a baby not responding to the ionotropes, and then you have to think of either coarctation or aortoarteritis. So this is a 40-day-old baby treated in a medical college by the pediatricians, and then the failure was not in control, and then it was shifted to us. What they had done was they had not recorded the BP in the upper limb, they had not felt the pulse in the lower limb. And when my assistant recorded the BP, it was 220/110. And she said, "Ma'am, I'm scared to go up to record the BP. And then I realized that felt the lower limb pulse. I always tell my students, touch the feet, be Indian. If you touch the feet, you'll never miss diagnosis of coarctation of aorta. Always be humble, feel the dorsalis pedis or posterior tibial pulse. If they are absent, the femorals are absent, that means it is coarctation. So here, ejection fraction was just 35%, and then we did the almost like a dead end aortic this thing opened up, and then ejection fraction improved to 55, BP came down. Now this is another baby, 20-day-old baby, feeding difficulties since birth, had sweating, urine output had come down, and then absent femorals were there, and BP was 130 in a neonatal period, and then echo gradient was 113. And you can literally see that it was like a dead end. We crossed it and opened, and after opening, the urine started improving, the cardiomegaly came down, and the patient became fine. And from 130, BP came to 100, and gradient from 113 came to 44. Now, this is another patient. Patient had rheumatic fever, mitral stenosis, atrial fibrillation, came in a pulmonary edema, and was posted for the balloon valvuloplasty for the mitral stenosis. And when I felt the femoral pulse, the pulse was not there. And I told my professor, sir, this is coarctation. He got very wild with me because all along the patient was treated as mitral stenosis of rheumatic etiology and in the pulmonary edema. And how can I call it as the coarctation? I said, I take bets, sir. The clinical acumen cannot go wrong. And then I did the aortic angio. You can see that literally it is a dead end. And then there was a small whip of dye going up. And I knew that there is a place. So I crossed it with the guide wire. And then ascending aorta angiogram showed a tight stenosis. Then dilated with the balloon. And this is the post-dilatation coarctation. In the same setting, did the mitral balloon valvuloplasty, and the patient made a very good recovery. Atrial fibrillation came down, heart failure came down, BP came down, everything was fine. Now, going to the other extreme is this lady had a stillbirth in the previous delivery, and then this time she ran. They did the cesarean section. The baby did not cry, and they put the baby on the ventilator. And the neonatologist, she asked me, Vijay, can you do something? I said, madam, send the baby. And the baby had a pinpoint aortic stenosis. You can see that this is a pinpoint aortic stenosis. So we crossed it with the floppy guide wire and with the PT-safe balloon opened up, and with just 4 millimeter PT-safe balloon, the blood started gushing. Within 24 hours, the edema fluid came down. The patient was weaned off on the ventilator, and then the gradient came down, and the patient made a complete recovery. And now the baby is so mischievous that the mother can't run behind him. So the gradient improved. So this is how we can see that the hydros fetalis, which is 100% mortality, can be saved with the timely intervention. This is a 15-day neonate, just weighing 1.8 kilo, and then we have opened up with the balloon and made a good recovery. This is a 4-year-old boy, came from North India, and nobody was ready to touch him, neither the surgeon nor the pediatric cardiologist. Then look at the left ventricle. It was so much like, non-compaction was there, pericardial effusion was there, and the patient was in heart failure. And apart from that, there was a severe aortic stenosis. And then you can see the doming and the thickened bicuspid aortic valve. I did the open with the balloon, and the patient made recovery, and the child started smiling soon after the intervention. And this is the critical aortic stenosis I've seen, the worst ever in my life. The gradient was 214 gradient across the aortic valve. Opened with the balloon, the patient made complete recovery. So heart failure with hypertensive crisis are seen very frequently, and most of them, they do not do well. So this patient had a hypertensive crisis, bilateral upgantro, convulsions were there, and at that time the patient was referred to me. And then you can see that the mid-thoracic aorta is the long aortoarthritis was there. So multiple dilatations I did, and there was a dissection, and with the self-expanded stent, now the patient made a complete recovery, and now the patient is a auto driver doing well as a teenager. This is another girl who was diagnosed as a pulmonary embolism, but then she had the aortoarthritis as well as the pulmonary artery stenosis. So this is before and that is after the balloon dilatation. And I have put two stents almost, fixing into each other. And this is how even the long stenosis can be controlled. Now, whenever there is a mitral regurgitation, in the past, they used to be treated with the drugs, especially ACE inhibitors. No more. Now, the functional mitral regurgitation or even other mitral regurgitation can be corrected. So this is another patient where the patient was treated as rheumatic fever with the congestive failure with the diuretics. Even if you immerse him in the drum of the diuretics, the patient is not going to recover. That is because you can see that in the echo, both the papillary muscles, the chordae are torn, and those torn chordae are flying like, like the kites. And such a patient requires surgery. Here, the repair becomes very difficult because the papillary muscles have to be stitched and the repair has to be done surgically. This is the 3-year-old girl with the rheumatic fever, caudal tear, flail non-compaction with the severe mitral regurgitation, and this patient with also had a non-compaction with the pericardial effusion and made a good recovery after the repair. So when there is a chronic rheumatic mitral regurgitation, you can see that the LA can be dilated beyond the RA. And this is the giant left atrium. And that giant atrium, left atrial plication can be done, reduction of the size so that the atrial fibrillation is controlled. And this is before and after surgical repair and also the left atrial plication for the giant left atrium. So this is the patient with the just 9-day-old baby, had an AST, coaptation, as well as the LV dysfunction. So this was opened, and apart from that, the PDA also was closed. So this is how we can do both the dilatation of the coaptation as well as the PDA closure. And this is the 16-year-old female, breathlessness, swelling of the lower limb, and then the pallor, edema was there, muffled heart sounds were there, and ejection systolic murmur was there in the pulmonary artery area. Echo showed a large atrial septal defect, pulmonary artery hypertension, and the large pericardial effusion and tamponade. And you can see that this is the swinging of the heart. And what is strange is RA, RV are dilated, whereas the LV is collapsing. Normally, we teach the student whenever the RA wall collapses, it's a tamponade, or RV wall can be collapsing. And here you can see that the LV wall is collapsing. That is because of the pulmonary artery suprasystemic PA pressure. So this is how this patient also had a pericardial effusion and also the pleural effusion. We tapped both the pleural effusion, and here you can see that this is the transverse fissure and the pleural effusion and pericardial effusion. The pigtail is in the pericardial space. So this is how we can revive the patient, whether in the pericardial effusion or pleural effusion. So reduction in mortality with drugs is very important. And today, FDA in 2015, they gave the approval for the ARNI. So ARNI is the which an inhibitor for neprosilin is there. So these drugs have remarkably changed the morbidity and mortality in the patient. So ARNI works by inhibiting the degradation of the compounds that promote the excretion of sodium in urine diuresis and vasodilatation. And hence, the combining these two drugs leads to significant improvement in the heart function. So when we cannot do the intervention or the conditions is due to the myocarditis or heart failure, then we have to go to the pharmacological treatment. So in the pharmacological treatment, in the past we had digoxin, diuretics, potassium sparing diuretics, ACE inhibitors, milrinone, dobutamine, dopamine, epinephrine, vasodilator, nitroprusside, and all of them, in spite of all that, morbidity continued to be very, very high. But today, a Fantastic Four have made an entry with the big bang. And John McCrae and Milton Packer, they called them as the Fantastic Four because this beta blocker, angiotensin receptor neprosilin inhibitors called as ARNI, sodium glucose transporter 2 inhibitors called as SGLT2I, and then mineralocorticoid receptors antagonists called as the MRA. So these are the 4 drugs which are called as the Fantastic Four, and these Fantastic Four have totally changed the metamorphose, the morbidity and the mortality. Now coming to the renin-angiotensin system inhibition, ACE inhibitors versus ARB or ARNI. In this, the recommendations are in patients with the heart failure with the reduced ejection fraction, where the NYHA class 2 or 3 symptoms are present. In this, you have to use the ARNI is recommended to reduce both morbidity as well as mortality. In patients with the previous or current symptoms of chronic reduced ejection fraction, use of ACE inhibitors is beneficial to reduce only morbidity. Now, coming to the renin-angiotensin system inhibition with the ACE inhibitors or the ARB or ARNI, then in patients with previous current symptoms, chronic who are intolerant to ACE inhibitors, they are having the renal problem, they are not able to tolerate, incessant cough is there, and instead of ACE inhibitors, and this ARNI can be used. And this is very, very useful. In patients with the previous or current symptoms of chronic reduced ejection fraction in which ARNI is not feasible, and then along with the ACE inhibitors, you can use the ARB, provides a high economic value. In patients with the chronic symptomatic patients, here we have to try the other drugs also. Now, renin-angiotensin system inhibitors, in this, the 6th point is in patients with the chronic symptomatic reduced patient, ARNI is a drug of choice. ARNI should not be administered concomitantly with the ACE inhibitors. Remember, combination of ACE inhibitors and ARNI should not be done or within 36 hours. If the patient is already in ACE inhibitors, stop the drugs, wait for 36 hours, and then start the ARNI. ARNI should not be administered to the patients with any history of angioneurotic edema because that angioneurotic edema can be worse. So ACE inhibitors should not be administered to the patients with any history of angioneurotic edema. Now coming to the beta blockers are the time-tested drugs and they are used to reduce the heart rate and also to reduce the oxygen requirement. In patients with the heart failure with reduced ejection fraction with the current or the previous symptoms, use 1 to 3, one of the 3 beta blockers proven to reduce mortality like bisoprolol or carvedilol or sustained release of metoprolol, succinate can be used. So any of these 3 drugs are useful. And in patients with reduced ejection fraction, current or previous symptoms, beta blocker therapy is recommended. Symptoms, MRA therapy provides a very high economic value and the value statement is almost A. And in patients taking MRA whose serum potassium cannot be maintained less than 5.5, and then MRA should be discontinued. So whenever you put the patient on MRA, you have to get the electrolyte balance to be maintained, and that is the dictum to be remembered. In patient with the reduced ejection fraction, the current or previous symptoms, use of is very important. And apart from that, now sodium glucose inhibitors are also useful. In patients with the symptomatic chronic SGLT2I are recommended to reduce the hospitalization and also the heart failure and cardiovascular mortality irrespective of presence of type 2 diabetes. So present diabetes is present or not present, these are the drugs which are recommended. And in these patients, the symptomatic chronic heart failure with now for patients as African American with the NYHA class 3 to 4 ejection reduced factor, in this patients, combination of hydralazine and isosorbide dinitrate is recommended to improve the symptoms to reduce the morbidity and mortality. So hydralazine and isosorbide dinitrate have to be continued in these patients to get the good result. Now, drugs proven for the therapy for value that may worsen the heart failure. In these patients, we have to see that dihydrogenated calcium channel blockers are not recommended for these patients. In patients with reduced ejection fraction, vitamins, nutritional supplements, and hormonal therapy are not recommended other than the correct specific deficiencies. In patients with the reduced ejection fraction, non-dihydrogenate calcium channel blocking drugs are not recommended. They are contraindicated. So the drugs of unproven value that may worsen heart failure are continued are when there is a patients of the reduced ejection fraction, thiazolide diuretics, they can worsen. And the patients with the type 2 diabetes, high cardiovascular risk, and in these patients also, the inhibitors or saxagliptin and the alogoliptin increase the risk of heart failure, hospitalization, and should be avoided in patients with the heart failure. In patients with the reduced heart failure, non-steroidal anti-inflammatory drugs worsen the heart failure. So never recommend these drugs combined with these things. Now, after the drug therapy, we go to the intramyocardial biomaterial injection. Intramyocardial biomaterial injection following clearly holds promise in the future. Still, it is at the practical level. So biological derived synthetic hybrid material like collagen, gelatin, fibrin, and alginate can be designed to infiltrate and to improve the patients after the myocardial infarction. And this is at the experimental level. And we know that arrhythmia can produce heart failure, and many times antiarrhythmic drugs also can cause the problem. So in arrhythmogenic right ventricular disease, sotalol is proven high efficacy. Patients with the induced ventricular tachycardia not responding to sotalol, they can go for the antiarrhythmic other drugs also. But amiodarone did not prove to be more effective than sotalol, and hence maybe instead of trying another drug straight away, we can go for the other drugs like verapamil and beta blockers and then go for the proper treatment. Now, what is the role of pacing? There was a time, the current philosophy is to use the pacing in a heart failure patient, assuming that mechanism will benefit the resynchronization of the ventricular contraction, especially in patient with the left bundle branch block. But the major studies are therefore evaluating biventricular pacing in severe congestive heart failure associated with the left bundle branch block. The quality of life of almost walking up to 6-minute distance NYHA class improvement is seen between 6 to 12 months. So beyond that, we do not know. Now, coming to the mechanical circulatory support, the mechanical circulatory support, because of reality now. So in 2013, every 1 in 9 death certificate was mentioned as the death due in the United States was due to the worsening of the heart failure. But today, the heart transplantation or even heart-lung transplantation is the best option. That is the gold standard. But unless that is available, many people cannot. So until the heart transplantation is done, until then, mechanical circulatory support can be used. So these mechanical circulatory support are of 3 types. One is the temporary, other one is the intermediate, and the third one is the durable. The temporary ones are the intra-aortic balloon pump. For example, we are doing the angioplasty and the patient crashes, the patient develops atrial flutter or fibrillation, and then at that time, IABP can be put, and then Impella 2.5 or Impella CP can be used in this patient as a temporary measure until the angioplasty is completed and the heart pumping comes back to normal. So we have a right heart support here. Impella R is there and tandem heart is also there. So this can help in the right-sided heart failure. So when there is a biventricular support is required, then we have the ECMO and the Impella CP, Impella R, and these are the varieties and they are all there. So in the market, we have a varieties of them. When to use, which one to use, where to use is a problem, and that anyone who's in the critical care managing the heart failure will know. So first is IABP, then Impella, and then tandem heart, Impella 5, ECMO, and then we shift to the failure. Now we have the Impella, world's smallest heart pump, and this is such a beautiful heart pump. This is the diagrammatic representation given to me by my student, Dr. Bhagirath, who is the consultant transplant cardiologist working in the Narayana Hridayalaya. And this is how we know we can put the pump into the left ventricle, and then the blood is sucked from the ventricle, and then it comes into the ascending aorta, and that can be helped. So this is how we know this Impella intracardiac pump can be introduced, and that too transcatheter. And this is worked so beautifully, and this becomes like a safe bridge for the heart to go for the cardiac transplantation. I use the word bridge, safe bridge. When do you say safe bridge? The bridge to recovery, bridge to heart transplant, or bridge to the durable ventricular assist device, that is the destiny. So whatever may be the one, the mechanical circulatory supports are only temporary and until the permanent transplantation is done. So mechanical ventilation should be instituted before the severe hypoxemia occurs, and then it should be instituted before hyperkalemia-induced cardiac arrest occurs. Once the cardiac arrest occurs, even if you put the assist device, it doesn't help. Circulatory support should be instituted before hypoperfusion induces the thing. So here, improve availability, accessibility, and temporary circulatory support system all are very important. Should all patients receive temporary mechanical circulatory support system in cardiogenic shock, and that will increase the survival. So now from the 1981, we have the cardiomyoplasty. Here, surgically, they take the transplantation of the myoplasty is done, and here the latissimus dorsi is taken as a muscle to wrap around the heart to improve the pumping. And of course, though thousands of patients have undergone this latissimus dorsi transplantation, but still it has not become popular. So friends, however attractive these recent advances may occur, but still crash can occur. And for that, the prevention can be done only by realizing what our Narayana Sutta told before the Vedas. They said that we think William Harvey is the father of cardiology, but in our own Dhanvantri, before the Vedas, it was told that the heart is the one which is like a bud down, the lotus bud downwards. It is keeping the temperature throughout the body well, and it is 9 inches below the neck, 9 inches above the umbilicus, and it is swinging. And this is the abode of the Vishwavyapi Paramatma. That means the Paramatma's Amsha is there in the heart, and hence it has got the function of Brahma, Vishnu, Maheshwara. For our cells to grow, for our cells to be preserved, to destroy our cells, the blood has to be pumped from the heart. And unless this Vishwarupi Paramatma is beating, until then we are alive. The moment it leaves, then we are dead. And hence today, despite all the advances we have made, we are unable to keep up that Paramatma's Amsha in the heart once the heart failure occurs. So the best thing that we can do is protect our heart so that we do not damage the myocardium. The muscle, myocardial muscle, is a unique one. It is a syncytium, and preserving and protecting is our bounden duty so that we don't land our patients into the heart failure, and prevent them in advance and put them in on the proper fantastic food and see that they don't go for the congestive cardiac failure. Thank you very much for your kind and patient hearing. And I'm very sorry for my bad throat and the bad presentation. Thank you.
Thank you so much, ma'am, for giving your valuable time and sharing your knowledge with us and making this session informative one. I definitely think this session knowledge is going to help all the participants who have joined this session. And I can see we have received some question from the participant. If you allow,
Please.
can I take this question?
Please, please.
The question is from Dr. Agarwal. He is asking, how have implementable diseases such as CRT and VADS impacted heart failure management?
I have not much experience in that because I'm a pediatric cardiologist, more into interventions rather than that treatment. Anyone in the group can answer that question.
Okay, thank you so much, ma'am. I hope that Dr. Agarwal has received the feedback. Moving forward, I can see another question from Dr. Snehali. She's asking, what are their new insights into the intersection between heart failure and other cardiovascular condition in pediatric age?
In the pediatric age group, invariably, we have left to right shunts. And if they are small, they can be managed medically. If the baby is not gaining weight, if there is a intercostal retraction is there, baby has got a sucrose suck cycle, we know that that is the indication that the patient has got a heart failure. So we do the echo, make the precise diagnosis, and then give the proper treatment. And we literally avoid patient going into the failure. So unlike the adult where they have ischemic heart disease or something or the other, and they come to the doctor only when the heart failure occurs, in children we can detect in advance and treat them. If there is an alkapa, anomalous coronary, left coronary arising from pulmonary artery, we do the echo, pumping is reduced, there is a glistening endocardium. In the short axis, we see the alkapa, we make the diagnosis, sent for surgery. So the heart failure can be prevented or treated in childhood. So we have many conditions where the surgical correction or the intervention with the device can help and prevent heart failure in children. So structural heart disease in children can be treated with the surgical or the non-surgical interventions. So the drugs don't have much role in the children.
Thank you so much, ma'am, for explaining it really well. I can see one last question from Dr. Subramaniam. And the question is, what genetic or molecular markers are being explored during tailoring heart failure treatment to individual patients?
The markers are many, and they are still at a thing, and they are also trying to find out which marker is better, and depending on the condition the markers also vary. So whether it is a Kawasaki's or whether it is a viral myocarditis, whether it is any of the conditions, the markers also can vary.
Thank you so much, ma'am, for answering all the questions. As I can see, there is no more question from the participant end. With all your permission, shall we conclude this session for today?
Yes, thank you so much.
Thank you so much, ma'am, for your valuable time. I hope to see you again with future also, ma'am, with different topic.
Yeah.
Till then, take care of yourself, ma'am.
Shubharatri.